Good morning, everyone, and welcome to today's webinar hosted by PYA. Today, we are continuing our Healthcare Regulatory Compliance webinar series with a presentation on 2023 Medicare Physician Fee Schedule Final Rule, Part 2. PYA is happy to present today's webinar on this important topic. You will have the opportunity to submit questions to today's presenter by typing a message into the question pane of the control panel. We'll collect these and address them by email after the webinar. All of our webinars are recorded and released with a copy of the webinar after the event. With that, I would like to introduce Valerie Rock, Consulting Principal at PYA.
Thank you, Laura. Appreciate your introduction there. And thank you all for joining us today for this webinar. Keep in mind, this is part 2 of 3 parts for the Medicare Physician Fee Schedule. It's hard to get all 2,953 pages in the long form into one presentation. So we're going to focus on the areas where I focus my attention mainly as I'm over the Revenue Integrity Department at PYA and work closely with the physician fee schedule and helping you navigate that. So appreciate you trusting us and continuing to trust us to provide you this information. Please know that we're not going to be able to cover everything through this 3-part series. So if you have any questions on additional areas that we don't cover, please reach out to us. Or if you have any questions on the content today, please let us know. We're happy to answer any questions that you have. Sorry about that. So today we're going to focus on evaluation and management services, the split shared services that have had changes and are being somewhat finalized for 2023, the practice expense calculations, Medicare Economic Index, the behavioral health expansion, the global surgical package, what they're thinking about that as of now, the dental and oral health services that they've finalized as paying for, and including their request for information, CMS's request for information for additional information. So we're going to walk through all of that during our time today, so appreciate you attending. So as you're aware, that we've had a 4.5% decrease in the conversion factor. So anything that I talk about in relation to the E&M services, the changes in those, the work RVUs that have been revised related to these changes, keep in mind that we also have the conversion factor that impacts this. In addition to that, there's practice expense changes that we'll talk about, and the changes to the geographic practice cost indices that also impact the total revenue that you would make at the end of the calculation for Medicare. And of course, that also impacts your other contracts and things like that. So there's going to be a downstream effect of all of these changes, but I would not look at any of the values that I've included for work RVU changes as a bottom line impact. So keep that in mind when you're looking at this. In addition to that, we've seen studies for impacts for these E&M changes that have reflected very different results depending on the practice or group or physician we're evaluating, because the utilization of the services, the change in coding that may occur based on the guidelines will impact the ultimate impact to your revenue. So an internal discernment on those and review of those services and how these are being impacted will be important in order to determine your total impact ultimately in 2023. The way that we've set this up is basically that this presentation is a tool for you, a resource that you can utilize going forward, so that as you're trying to implement these changes and understand these changes, this can be something you look back to say, oh yes, we've got some differences between CMS and CPT here, so we need to consider these guidelines and these differences so that our coding teams and our billing teams and our physicians understand the impact of these changes. There's a lot of nuances to this, and it's going to be very difficult to really train and bring this up to speed. So, continue to use this in the future as you're implementing these. So we'll talk about the CPT policies, the CMS policies that are different or the same from CPT as they've changed them, and then the CMS work RVU evaluation ultimately that was finalized in the final rule. If you were present for the presentation that we did on the same topic for the proposed rule in August, you'll see much of the same content, but it has been updated based on the final rule. So it's in that same format as we presented before. As a reminder, what you'll see in the E&M guidelines and in the CPT update for 2023 is that we still have the office and other outpatient services as they were revised in 2021. So we had the CMS adopted those guidelines in 2021 for the office and other outpatient codes, which is your 99202 through 99215 services. Those E&M services have not changed. The guidelines have not changed for 2023. The valuation of those codes have not changed since 2021 either, but the impact of the changes that occurred in 2021 are still being felt today because the adjustments to those changes in value were pushed down the road. So now we're getting a good bit of the full brunt of the impact, which is why you see a negative adjustment on the conversion factor. Keep in mind that CMS and CPT expect us to provide or the physicians and MPPs to provide a medically appropriate history or exam when they're providing their E&M service, even though that history and exam are no longer required for the level of service determination. It still is appropriate to include a history and exam as medically appropriate. You have hospital conditions of payment, IPPS rules, et cetera, that are impacted by the documentation of physicians. So ensure your training is comprehensive to support all types of documentation that are required across the hospital and the physician clinic so that they understand fully what they should be documenting. But in essence, they should be documenting what they're doing that is medically appropriate, that is medically necessary, and supporting the service that they're rendering. CMS has included in their manuals, and MACs, the Medicare Administrative Contractors, have included on their websites many of these policies already, and they are incorporated into the manuals, but watch for additional updates in 2023 as these are pulled in for these other services as well. One of the guidelines that you'll see from a CPT perspective is a statement that says a continuous service that spans the transition of 2 calendar dates is a single service, and it's reported on one date, which is the date the encounter begins. If the service is continuous before and through midnight, all the time may be applied to the reported date of service. I want to mention this because this is a concept that is applicable to some of the services. But as we talk about the observation and inpatient services, CMS is saying to apply the 8 to 24 hour rule, and that they're going to maintain that rule, and we'll talk through that specifically. In addition, CPT allows for the use of the subspecialty, not just specialty, but subspecialty, in determining whether an initial service can be billed or if a subsequent service should be billed. So CMS does not look at subspecialty or identify subspecialties at all. So because of that, you would not use the subspecialty as a determination on when to bill an initial service. You would just go to the specialty level. You'll see this range of 48, a negative 48% adjustment to a positive 32% adjustment on the swings of changes that have occurred within these other E&M services. But what you'll find is that those big swings occurred to the lowest volume of services. So it's not likely to impact your bottom line in a great manner. So keep in mind that there are, adjustments published within the fee schedule that say things like -3% for interventional radiology and 4% for infectious disease as a total revenue impact. But again, because each provider is billing uniquely to their patient population, looking at an average of that population across the nation is not giving you a good indication of the full impact of these changes. So monitor these changes over the year as they are, really implemented, as the education is provided for E&M services, and that as you find that the physicians fully understand these concepts, hopefully that you will then see a change in the coding, which then may impact revenue further. So let's start with the hospital inpatient services. Again, CMS has adopted the 2023 E&M guidelines. So the AMA has put forward the E&M guidelines that are published in the CPT manual. So CMS no longer has the, they're not going to change or push out or anything, the requirements on the 2023 E&M guidelines. The 2023 CPT manual is inclusive of all the E&M guidelines from 2021 to 2023. It's all one set of guidelines. So now we won't call them 2021 or 2023 guidelines, we'll call them E&M guidelines. And they will be the only guidelines that are appropriate to bill for or under as of January 1 of 2023. The 1995 and 1997 guidelines are sunset based on that. So as we look to the CPT policy, CPT revised the inpatient visit codes to include observation codes, which means that the descriptor of the hospital care codes now are inclusive of observation, and the observation code set is now deleted. So now we have one code set for hospital, inpatient, and observation services. This has caused a change in valuation in addition to the change in coding guidelines. CMS policy does not allow for an outpatient E&M to be billed separately for an inpatient E&M on the same date. So make sure that you're billing those as one as an inpatient E&M and not allowing them to be separate, even though CPT allows it to be separate. So any policy or any payer that is paying you according to CPT guidelines, which if they do not assert the CMS guidelines, then they're effectively doing that, that you would follow the CPT guidance for those payers not asserting the CMS guidance. And for anyone asserting the CMS guidance, you would follow CMS rules. Swing bed services are going to be billed based on place of service. So if they're performed in the hospital or the nursing facility, you would bill based on place of service. And then transition from observation to inpatient status does not constitute a new stay. So you'd be billing that all as one. And then only the provider that is overseeing or responsible for the discharge services can bill the discharge codes. So you would then bill any other providers with the 99231 or 99233. The volume of hospital care and observation care services are in the subsequent visits generally. And you see that there's quite an upswing of value for the work RVUs. 14, 32, 20%. So you are seeing a good increase for those work RVUs. Again, you have the negative adjustment on the conversion factor, but you should see an uptick overall. However, keep in mind that the actual coding of the services based on medical decision making or time could impact the actual volume of codes in the future. If your physicians and NPPs are coding in the exact same manner from today into January, because they don't understand the guidelines or they don't fully appreciate all of the aspects of that, then you could end up with this increase kind of basically straight across. But if you do have any decreases from a 3 to a 2, for example, because the qualifications of the diagnoses in the medical decision-making requirements that say that you have to be addressing the diagnosis, it can't just be one of the diagnoses that are complicating the situation. And then the risk to the patient is very subjective and based on the physician's determination, but there's some examples within the guidelines for that that reflect that in some cases you may have a 3 today that may be a 2 tomorrow. So keep a lookout for that, because there will be some shifting of the volume of codes in the future. Observation codes, again, have been deleted. So the observation category of service has been deleted as its own grouping, but they are inclusive in the inpatient codes now. So you'll have that one set of codes of 6 codes, and you'll bill based on those. Again, the CPT policy allows for billing of an outpatient E&M and inpatient or observation service on the same date, but CMS does not allow that. And here's where this 8 to 24 hour rule comes into play. It is now being applied across the observation and inpatient codes. There was some misunderstanding and the verbiage was not complete in the proposed rule. So they've clarified that really the line runs along the 8-hour piece. If you have under 8 hours and it's the same day or a different day, then you would only use the initial hospital service codes. If you have more than 8 hours and the service is done all within the same day, so you're admitting and discharging the patient within the same day, you would use the admission and discharge codes. If you have more than 8 hours and the patient is discharged on a different day, then you can use the discharge codes in addition to the normal admission codes, the 99211, 221 through 223, and then the discharge code separately. So everything's going to hinge around whether it's less than 8 hours, more than 8 hours, is it the same day or different day? So what you'll see in the final rule is that they've included a table that will allow you to have kind of a decision tree, if you will. So if you want to print out that or print out this and provide that to your billing team, to your coding team, so that they can see what that differential is, how to make those decisions. If you have this built into your charge master, you want to make sure that that's included in there, and so that the proper code can be billed out. CMS did clarify that the 24-hour stay is not required to bill the same day admission or discharge service. And so there was some question on whether you had to have a full 24 hours in order to bill that, but they said no, it's just 8+ hours. The valuation, or basically the work RVUs that were in the observation codes and the inpatient codes, were not that different. So the difference in the value of these codes is the same, effectively the same as the inpatient changes that you saw in the previous slide. Again, the 99222 is effectively a 0% change. A lot of the volume will be in that level 2 initial service, but those subsequent visits tend to be the highest volume because you're seeing the patient routinely after that initial visit, and those volume codes will have an increase. But that change is basically mimicked into the observation codes as compared to 2022. In regards to the ED services, we also have a change in the guidelines here, but they did not add any time component to ED services, so you'll only have medical decision making to use for the level of service. The biggest change here is that the 99281 was changed to a nurse visit, and the levels, the 4 levels of medical decision making were applied to the remaining codes. So the level 2, level 3, level 4, level 5 are straightforward, low, moderate, and high. So now you have just 4 codes that your physicians will be using, which creates a crosswalk, which I'll share on the next slide. We'll continue to, CPT will continue to allow the ED and critical care to be billed on the same day, but CMS clarifies that you have to document that the ED service was provided before the critical care and that they were truly unique services in order to bill for them separately. There's also specific guidance within the CMS final rule that states that if the ED physician requests a patient's physician to come in and determine the patient should be admitted, the patient's physician will report the initial hospital care visit. The ED physician would bill the ED code. So they're not, and again, they're not dropping the same day policy for critical care and ED visits. The RUC, or Relative Value Update Committee of the AMA, had originally recommended a decrease for the 99284 on the work RVUs, but CMS did not agree with that, and they've finalized to not agree with that. So the only change to work RVUs within the ED services is the 99281 that is now a nurse visit, and it will go from a 0.48 to a 0.25. I want to share this crosswalk, as I just mentioned, because again, the volume of services as compared to the change in work RVUs matters. The national distribution for ED services for the Medicare E&M bell curve is 87% of the services are billed at the 99284 and 99285. As you see, there's a 0% change to the work RVUs for those 2 codes. However, if you miss that the change in the coding from now the 283, the 282, 283, 284, 285 are going straightforward, low, moderate, high, and it used to be that the 99281 was straightforward, 99282 was low. We had 2 moderate codes. This is all medical decision making level, and then the high at the 285. So you would think that, okay, well, now the 283 will be a 284. But we've actually had a client do a study of this and evaluate, will all the 283s go to the 284? And they found that that was not necessarily the case. About 50% of those 283s became a 284, and 50% were still a 283, which means that you will see an uptick in value of your ED services, like basically an increase in revenue, but it will not be basically a crosswalk from a 283 to a 284, if that makes sense. So monitoring the coding, monitoring the understanding of the coding, the guidelines, that the physicians understand how to code based on these guidelines. Maybe you have an outsourced ED department, ensuring that they understand the requirements will all be very important to getting these levels right and to getting the valuation and projected valuation right. But at least we're looking at an increase in revenue overall, most likely, unless the physicians just do not understand the change, which would mean you basically see a 0% change. The skilled nursing facility and nursing facility visits have also changed just in the same manner. So CMS adopted the 2023 guidelines. CPT has a lot of specifics in their requirements, and CMS kind of has some differences there. Specifically, CPT says that an office visit or ED visit on the same day as a nursing facility initial assessment can be billed separately, whereas CMS says that it cannot be billed separately. CPT policy says that NPPs can bill an initial nursing facility code if the initial comprehensive can be performed by the NPP according to that state. so that they could bill that initial visit. Otherwise, they would bill the subsequent nursing facility visit if they perform a service prior to the initial service of the physician. And all other physicians basically would be billing that subsequent code. Also, CPT lays out clearly within their guidelines that the NPP is considered the same specialty as the physician in which they're in the same group, such that they would only bill one initial visit between all of them if they're all a part of the same group. Again, swing beds will be billed based on the place of service, and CMS does not recognize subspecialties for the initial visit determination. One of the things that we saw the Rock and AMA talk back and forth within CMS within the final rule was related to the top codes in each of the sections for the nursing facility visit, because they were both at 45 minutes. And the RUC provided an explanation of why that was still different, that the evaluation of the subsequent was lower, and this is why, and so there was an agreement to that, and that value was adopted. Then there is a deletion of the 99318, and CMS asked for how this might impact, asked for comment for how this might impact everyone, but in the end agreed that the 99318 would be deleted, that they did not need to include a G code for this service, and it's anticipated that generally providers about 85% of the time would use the 99309 for this visit, which would be basically an increase in value by a couple points. The home or residence services, the guidelines again have been changed, but now we've lost the section that used to be called domiciliary rest home and custodial care services. So those have been deleted, and all the home care services or residence codes are one, similar to the inpatient and observation. Now we have one set of codes for all of this, and they will be medical decision making or time-based. Because of this shift as well, and because of we only have 4 levels of medical decision making, the 99343 was deleted. So whereas we had a repeat in level of the ED services, and they just basically made that first level a nurse visit, in these codes, they just deleted that middle level of service altogether. So again, when you're looking at these valuations on the right and you see a negative 15% adjustment, keep in mind that that 99343 will probably be billed as a 99344 now. So you'll have an increase in revenue on services that used to be a level 3 and a decrease in revenue on the 4s. So you'll probably have a little bit of a net effect there. We now have the prolonged service codes published, the 99418 for CPT for the inpatient observation, and basically all of the other codes. You can use the 99418 for the prolonged service time, but the way you determine the prolonged service is different from CPT to CMS. The time on the CPT side is met once you surpass the minimum time in the CPT descriptor by 15 minutes. So you have a range of time, use the lower amount of that time, and once you pass 15 minutes in excess of that, then you can start billing your prolonged service codes every 15 minutes. CMS did not agree with utilizing one code for all of these places of service, because they want to be able to track the utilization of the prolonged service in each place of service. So they have a code per place of service. They're also 15 minutes. They're also with or without direct patient contact. However, the time utilized is based on the maximum of the code, and in fact, it's based on the physician's total time. So total time file is within the Medicare physician fee schedule. It is not published within CPT. So you would need to have the list of physician times that are total times inclusive of pre-service, intra-service, and post-service time, so that you are exceeding that total time by 15 minutes before you start billing the prolonged service code. This is not a good indication of administrative burden reduction. So CPT is going back to the drawing board and trying to figure out how they can align with CMS with this to make this, easier for everyone to apply these prolonged service codes. But at this point, we have two different sets of codes, two different sets of guidelines. But we do have a valuation on that 418 at 0.81 for 15 minutes and 0.61 for each of the 15-minute increments, which is basically an increase for the prolonged service. If you look at the hour and additional like 30 minutes that you used to bill. Wanted to include critical care here. There's only one piece of critical care change, but if you have not been brought up to speed on the critical care changes, especially as they relate to the split shared visit rules, it will be very important to review those rules within the Medicare manual, understand those rules, excuse me, and to apply those rules correctly. The clarification is that the second code for critical care, the 99292, that allows you to bill those additional 30 minutes, requires a total of 104 minutes. There was a question, or I guess a typo, or that they missed, that they did not update the previous time increment for the split shared side. Whereas they said 104 minutes in the follow-up care section, they did not include that in the split shared side. Now they're clarifying, actually we meant 104 minutes for both sides. Technically, this will go in effect on January 1 of 2023. It's finalized as of January 1, 2023. So if you have anyone going back to prior services based on that, it would be technically inaccurate to determine you as incorrect in utilizing the previous and published requirements. But it would be important to go ahead and implement that now and ensure that your providers are meeting 104 minutes in order to bill that 99292. The problem with this and the importance of this is that you want to continue to communicate to CMS the impact of these changes to critical care services, to the utilization of the providers, the mid-levels, NPPs, APPs, whatever your terminology is of that, if you're NPs and PAs. It is important to continue to utilize those NPs and PAs in the critical care setting. They're most commonly seen there, and but if we shift this, or as we've shifted this to time, you're getting paid 85% of the fee schedule based on these changes if you're not meeting the split shared time requirements, which is more than 50% of the total time. Most commonly, NPs and PAs are the ones that are staffed all day within the critical care unit, and the physicians are rounding in the morning and the afternoon, but they're not there all day, and so the time that they would be spending is not likely to exceed the NP or PA time. And so you're anticipating, or probably are seeing, a negative adjustment on your revenue there, or maybe have made changes to the way you're providing service. But we would recommend communicating that to CMS, because I don't think the intent is that we decrease the team collaborative approach. We want to continue support the team and collaborative approach to providing care, but some of these changes are discouraging that. So let's talk about split shared visits. I'm providing an analysis here because I think it's important to understand the detail behind these changes and what they've said on its face. What I'm hearing from the MAC phone calls and things like that, that there's some expectations that are not clearly in the guidelines, that they're basically asserting beyond the guidelines. We're also seeing MAC guidance that is published that is beyond the CMS guidelines. So you want to continue to have conversations with your MACs, get in alignment with what is appropriate to do to support these services, and ensure that you are understanding the requirements. Because if you look specifically at just the summary that's provided by CMS, all you will see is that the substantive portion of the visit, in order to meet the split shared visit requirements and to bill under the physician, is that the physician meets or provides one of the three key components: history, exam, or medical decision making, or more than half the time spent by the physician or MPP performing the split or shared visit. The problem with this is that we've had a change in guidelines, or will, as of January 1, and meeting one of three key components has a different definition starting in 2023, whereas in the 1995 and the 1997 guidelines, we had a structure to identify what is the complete history or exam that would have to be supported by the physician. Now, the summary does not say complete one of the three key components, but the 2022 final rule does. In addition, as we look over to the manual, let me jump over here real quick. The manual, Medicare Claims Processing Manual, states that the practitioner who bills the visit must perform the component in its entirety in order to bill. And they state that over and over again, whether it's history, physical exam, or medical decision making, that they're required to perform all portions of that aspect. Now, what does 2023 define as a complete history or exam? It is only that it includes a medically appropriate history or physical exam when performed, and that is determined by the treating physician. So now we have a physician that basically has to state they're providing a medically appropriate history or physical exam for the level of service, but you do not have a determination of the level of service in order to bill and support a level of service in a split or shared manner. The documentation requirements, as they are published as of right now, state that and this is through CMS directly, that the documentation in the medical record must identify the physician and NPP who performed the visit, the individual who performed the substantive portion of the visit must sign and date the medical record, and then one of the practitioners must have a face-to-face, in-person contact with the patient, but it does not have to be the physician. It does not have to be the practitioner that is performing the substantive portion of the visit. And so the substantive portion of the visit can be entirely billed with or without, or performed with or without direct patient contact. This has been further defined within some of the MACs. Some of the MACs just state this clearly and directly from this guidance. Some of the MACs are stating that both the providers have to provide in-person contact with the patient, that they both have to document their portion of the service, and none of that is stated within these guidelines. So contact your MAC to get clarification on these policies, providing them the requirements as published. It's okay to clarify how to document what is required, but that requires something above and beyond what Medicare is stating. I would ask them to clarify how they have the authority to do that, especially when they're doing it on their website and not through an LCD process that would allow for comment. Now, all of your services that are billed in the split shared service context have to use the FS modifier. So even if a physician and an MPP are performing a service on the same day, the physician provides a substantive portion of the visit, you would still need to use the FS modifier. The issue with this is now you have a data element that is out there that if you're utilizing a high number of split shared visits and you have a high number of FS modifier, you could be audited. So it is important to get in your structure how you're going to document these services, how you're interpreting the requirements of these services, especially since they are so subjective. So I want to show you also how, where this is truly subjective. So again, the history and exam and the 95 and 97 guidelines, based on the 22 final rule, required a complete service. That is, I'm sorry, I think I may have that backwards. So the history and exam are subjective because they only require a medically appropriate history or exam in the 2023 guidelines. So you still have to have a complete history or exam, but medically appropriate is the only definition of that exam versus the 95 or 97 that had a lot of specifics within that, and that was more objective at that time. Now we have subjective guidelines that are based on the physician's determination. Medical decision making and time are of course documented all the way through, do have more objective requirements, even though there's some subjectivity within these new guidelines. So those are a little bit more objective, but if you are meeting medical decision making in the one component of service that you're supporting as the physician, you are in effect supporting the entirety of the service, and there is no question of what the level of service is. And so medical decision making is the safest component to document as a physician and to support that you are indeed supporting the level of service. In effect, you're supporting it on your own. So in my mind, it's not even a split or shared visit, even if the NPP provides service. But you may want to build an FS modifier if it's not clear who all is providing what. You would want very unique documentation around the physician for those medical decision-making components. I did skip one slide, but this is basically showing that the Medicare physician fee schedule final rule for 2023 indicates the same and reiterates that the E&M visit requires a medically appropriate history or exam in accordance with its code descriptor, which is not clear, to qualify for the substantive portion when performed. So this is going to continue to be a concern. We do not have to implement time as the only component until 2024. As of right now, we would want to look for the 2024 proposed rule and provide lots of comments in regards to this, because I don't think that this is the direction that we should be heading. We've got to get this to where it would be easily audited, easily defensible, and easily communicated on who's providing what. It's understandable that we would want to know who's providing what portions of the service, but we do want to support collaboration and the ability for an APP to provide the top level of service that he or she can provide in any setting, and this helps for physician shortage issues. So we will move on now to the practice expense calculations and the MEI components. Basically, as a part of the practice expense changes, we're implementing the second year of the clinical labor pricing update, but CMS is still seeking comment on trying to determine the best way to get practice expense to keep up with changes in costs that are occurring pretty rapidly, as we've seen in the past few years. The market trends are hard to keep up with. If we're basing something on 2006, for example, we're not going to be understanding where we are in 2023. So in addition to that, the MEI for the geographic practice cost indices, the GPCIs, are also based on the 2006 MEI. As of right now, for the calendar year 2023. CMS is still trying to figure out how to get this right. So if you have any decisions or ideas on how to calculate this in a way that would keep up, that survey data would keep up with this information, please share that. In the same manner with the Medicare Economic Index, CMS actually finalized rebasing and revising the MEI for 2023 based on the 2017 cost weights. They've included some technical revisions to that as well, but they're not actually implementing the rate setting to 2023 based on that. They've just finalized the concept. They said that basically this would be a 3.8% update, and it's based on data in the 2017 based MEI through quarter 2 of 2022. So because of the substantial changes that would occur at the specialty level versus the entirety of the physician fee schedule, because it doesn't impact the entirety of the physician fee schedule, it just impacts components of it. So, individual practices or individual specialties might be impacted by that change. So they're not implementing it so that they can have some transparency on that ahead of any change. Behavioral health services have been expanded as well. The way that they're doing that is by allowing certain professionals to provide service under general physician supervision versus direct supervision for those services that are performed incident to. So this allows more expansion for these services to be provided without having the physician to be in the suite at the same time. It also allows CMS to pay for the behavioral health integration services by certain providers when they're part of the primary care team. They are also going to pay for opioid treatment programs that provide services in mobile units, as well as those that initiate treatment with buprenorphine via telecommunications. They have added a G code or 2 G codes, a monthly bundle of services to pay for the comprehensive treatment and management of chronic pain. You'll see them as CPM or chronic pain management services. The G3002 is the monthly bundle for the first 30 minutes that must be met all the way to 30 minutes in order to bill. And then G3003 for each additional 15 minutes with a max of 3. So you could bill the 3003 times 3 at a max per month. If you are anticipating wanting to bill these services, please look at the physician fee schedule final rule for all of the components that are included in these services. Look for any additional guidance and MLN matters and things like that are going to provide you additional context for all the components that are included here. And think of them as your kind of chronic management type of codes, your kind of transitional care management or chronic care management type of codes, capturing that time in a similar manner, making sure that you're documenting the actual time and including that and billing on the appropriate date of service, so that you're not exceeding the number of services that you can bill, and that you're capturing everything that you need to in order to support the monthly bundle. But this is definitely a recognition of the services that are provided outside of your normal E&M service or other management services during the month. The global surgical package question has been ongoing for a number of years, and because of one of the rules that came out, the macro rule that came out, it postponed this and requested more information. So the CMS went to all the providers and said, okay, how do we do this? And then there was an agreement that they would start requesting the data for the global, the E&M service that's being provided within the global to be actually billed in certain circumstances. So you might have been one of those that have been billing your E&Ms that are associated with your global surgical package, even though you're not getting paid for those separately, in order to gather the data. So RAND was requested to gather this data, to pull this together and determine, what is the difference between how many E&Ms are being included in the global surgical package currently versus how many are actually performed today. Could it be a difference in technology? Could it be a difference in standard of practice that has occurred that is decreasing the total number of E&M services that are actually valued within these services, such that we are overpaying for the global surgical package? And RAND did find that there were less, but there was a lot of scrutiny on the report that RAND had. And so then they're still trying to get consensus around this. And they requested more comment in the proposed rule. And they received many comments from the industry. But as it states here, the public still has no consensus on the issue or the strategy for valuing the globals. So it is really important to continue to communicate with CMS in regards to your position on this. Certainly, the way that we're moving towards more team-based approaches, more delegation of services, we're starting to see APPs that are being pulled in to do multiple pieces of these services, whether it's the pre-service or the post-service, or it's being delegated to a completely different physician. So if we're going to have team-based approach, it may be that we have to unbundle these E&M services. I don't think that's a popular position, but it would at least allow us to see who's actually performing what and to value it appropriately. But if we're going to bundle these services, we've got to get the value right. We've got to understand how many E&Ms are really being performed. So there's some options that they have proposed still to this date, and they're trying to get some more feedback on these options. So please submit your comments continuously and provide your feedback as you have your opinion on this. In regards to the dental and oral health services, there is a finalization, and CMS actually codified that Medicare Part A and B can bill dental for, that we can pay for dental services that are integral to the treatment of a medical condition. So what you'll see is that there's certain examples of when this could be billed that they have recognized. So you would want to bill within those that they have recognized and then provide recommendations for future inclusion of these types of services by February 10th of each year to this email address that they have provided, at Medicare Physician Fee Schedule at cms.hhs.gov. So be sure to be collaborative in this process. They're basically saying that services that are surgical, that require dental services ahead of time, that those services would be supported and billable in a medical type of scenario versus just dental. So as a reminder, the final rule is effective as of January 1 of 2023. So we want to make sure that we're ready for those changes. And because E&M changes have been pushed through CPT and AMA, all of those guidelines are in effect as of January 1 of 2023. And now that we have a final rule from CMS, we're seeing that we're moving forward with all of those changes and need to have them ready to go as of January 1 of 2023. So we would recommend providing education to your providers and regular audits of their E&M services for those inpatient and other facility services as they start adopting and understanding how to bill those services so that they do not end up incorrectly billing, underbilling or overbilling. Because as you've seen, those valuations, the changes to the valuation, changes to work RVUs, and the changes to the coding and the guidelines are all impacting revenue downstream. So we're happy to answer any questions that you have after this, please provide those questions in the chat or via email after this presentation. We're happy to answer any questions that you have. So now I will turn it back over to Laura to close us out.
Thank you. And thanks to our presenter, Valerie Rock. If you have any questions, her presentation and contact information will be emailed to you, along with a recording of today's webinar. Also, if PYA can provide assistance with audit, tax, compliance, valuation, or physician services, please call or email us. You may also visit our website at pyapc.com for more details about our specific areas of expertise, or to subscribe to receive PYA insights. Please remember to stay on the line once the webinar disconnects to complete a short survey. On behalf of PYA, thank you for joining us and have a great rest of your day.